Hi, everybody. It's such a pleasure to be with you today to talk to you about COVID. I wish that we could be together in person, but I recognize that the circumstances are going to be challenging for some period of time. Um, so today I'm going to talk to you about two topics. The first topic is what a rheumatologist should know about COVID-19. And then in my second talk, I'll tell you about the work that we have all done together with the COVID-19 Global Rheumatology Alliance. So let's start with what a rheumatologist should know about COVID-19. Here are my disclosures and an outline of what I'll talk about for this first talk. So we'll talk about the intersection of rheumatology and COVID-19. And I'll spend a majority of the time providing an update on some of the drugs that we use in rheumatology and how they're being used to treat COVID-19. Much of what I'll say is drawn from the work that I have done on the NIH COVID-19 treatment guideline panel. This was a panel that was convened by Dr. Tony Fauci to provide guidance to clinicians about how to care for COVID-19. I just want to say that I don't speak for the panel, so the opinions that I'll tell you today are my own. We will talk about hydroxychloroquine, steroids, JAK inhibitors, IL-1 inhibitors, IL-6 inhibitors, and colchicine. And I will review with you what the clinical trials have shown to date. So let's start by talking about our perspective as rheumatologists. We know that there are aberrant immune responses in COVID-19 that lead to organ damage. And some of these are very similar to what we see in autoimmune disease. We also have seen that many of the drugs that we use to treat autoimmune disease are being used for COVID-19. And I think the community is interested in our perspective as rheumatologists, thinking back to the last 2 decades of using immunosuppressive drugs in rheumatology. We've learned a lot. So one of the things that we've learned is that peripheral blood cytokine levels are very imperfect biomarkers for immunopathology. And we're seeing that in COVID too. Some patients have elevated IL-6 levels, but other patients don't. And it's not a perfect biomarker for disease severity. The second thing that we know as rheumatologists is that there's no single biomarker to identify an aberrant immune response. In fact, as rheumatologists, we're now moving towards using multi-omics, looking at single cell gene expression and genetics to really try to understand what's going on. And I think this is also true in COVID-19. There's no single biomarker. The immune system is complex, and I think the world realizes now the analogy between COVID and rheumatology. As rheumatologists, we know there's enormous immunologic heterogeneity between individuals. And we also know that many of the drugs that we use have significant side effects. One thing that's been very interesting in looking at all the trials for COVID-19 is that the safety profile of our drugs used over the short term has actually been very good, and that's very reassuring. Okay, so let's just talk about the key immunologic features of COVID-19. And I'm not going to go into too much detail here, but I wanted you to just be aware of a few things that the literature has shown. So the first thing is that we see elevated levels of pro-inflammatory cytokines, including TNF and IL-6. And some people sort of refer to this as a hyperinflammatory state. We also see that IL-1 related pathways are upregulated in severe cases of COVID. And this is, one of the reasons that people are using some of these drugs to treat COVID. We also see a delayed but very intense type 1 interferon response in severe cases. I think one of the most fascinating things for me about research in COVID over the last few months has been the identification of antibodies to type 1 interferons in the patients that get very severe COVID. What this suggests is that in some people, these antibodies are actually preventing their innate immune system from fighting the infection. And this is probably why they get such severe disease. Now, we've known for a long time that some of our patients, including people with lupus, also make these type 1 interferon antibodies. But I think we still have a lot to learn about the relationship between these antibodies and infection. And maybe some of what we've learned from COVID will help us, identify which of our patients are at risk. It's a very interesting area. So you all know this, but COVID has many stages, and it's for us to about the full spectrum of disease, because this is not just one condition, and the treatment for these different phases is very different. So we know that about 50% of people don't have any symptoms at all. And among the people that do have symptoms, 80% have just mild flu-like symptoms. 15% of people have a pulmonary phase of disease where they might experience shortness of breath. And then it's really only 5% of people that develop a severe inflammatory state and organ damage. For example, they develop ARDS or cardiac manifestations. And I think most of the treatments that I'll talk to you about today are really focused mostly on phase 2 and phase 3 of the illness. So let's go through the guidelines and some of the drugs that are being used to treat COVID. And again, I'm going to draw from the NIH COVID-19 treatment guidelines, and here's the website that has more details about what I'll talk about. The guidelines are organized into outpatient management, critical care, and then the care of the hospitalized patient. And I'll focus on our rheumatology drugs. So the immunomodulators is what I'll focus on during this talk. So I'm not going to spend a lot of time talking about hydroxychloroquine. At this point, the randomized trial evidence is very clear. Here I've listed the data that we have in hospitalized patients, in outpatients, and also studies that have used hydroxychloroquine to prevent COVID-19. And all of these studies, every single one, has been negative. So hydroxychloroquine really doesn't work for any phase of COVID-19. Let's move on to talk about steroids. So the reason that people were interested in using steroids is that they noticed that the systemic inflammatory response in COVID-19 was leading to lung injury. And steroids have such a broad anti-inflammatory mechanism that they were a very attractive target, early in the pandemic. And, at that point, we had some data from the ARDS literature that found that there was reduced mortality in people who got steroids. Although, that evidence is still evolving, but it looks like there was, some benefit. And, there's also the benefit of dexamethasone being inexpensive, widely available all over the world. And dexamethasone doesn't have mineralocorticoid activity like some of the other steroids that we use. So people don't get as many side effects like edema. So, the thing that really changed clinical practice very quickly was the recovery trial. And this trial is now just very famous, and we, I think, have a lot to learn about, how these investigators were able to do this very large trial over such a short period of time. It's just remarkable. But this was an open label, randomized controlled platform trial, meaning that they added different therapies as they got, more evidence as the pandemic went on. It was done in hospitalized patients with COVID in the United Kingdom. And the average age of people who participated was 66, although some of them were older. 22% were more than 80 years old. And people had various types of disease severity. So 24% of these patients didn't require any baseline oxygen, 60% required oxygen, 16% were mechanically ventilated. And what these investigators did is they randomized people in a 2-to-1 to 1-to-1 fashion to receive either no additional treatment, so that was the control group, or to receive hydroxychloroquine or steroids or azithromycin or a combination of antiretrovirals. And then as the trial went on, people could undergo additional randomizations, for example, to convalescent plasma or to tocilizumab, and I'll show you some of that data. So you've all seen these results from the recovery trial that really changed the way that we take care of COVID, but I'll just review them shortly here. So the first panel includes people who are mechanically ventilated. So this is the sickest group of patients. And you can see that dexamethasone reduced mortality by almost a third in these patients. So a remarkable benefit in this group. The middle panel are the people that are just on oxygen, but not ventilated. And in these people, the benefit is still there, although it's much, much smaller. And then we have the people who are not on oxygen. And in these people, you actually see that the curves are reversed. So the people on dexamethasone look like they're doing a little bit worse. This didn't reach statistical significance, but it's the reason that we recommend against using dexamethasone in the outpatient setting or in people who don't require oxygen. One other point that's important is that in the recovery trial, they did some subgroup analyses, and they found that the people who benefited from dexamethasone were these people that were more than 7 days from the onset of their symptoms. So the people not on oxygen or the people who are very early since symptom onset, it looks like the effect is null here. But it's really these people who are later in their disease who benefit. And since the recovery trial has come out, there have been a number of other studies. This is a meta-analysis of trials looking at all of these different regimens of steroids and slightly different patient populations. And because recovery is so big, with 3,200 people, the effect estimate really sort of determines the outcome of the meta-analysis. But it's important to say that some of these trials, although they're small, did not demonstrate as much of a benefit. But overall, I think the entirety of the evidence does seem to suggest that steroids have a mortality benefit in people with COVID-19. So back to the NIH guidelines. Basically, the recommendation is that depending on disease severity, dexamethasone can be used. And the 3 situations in which it's recommended are the people who are hospitalized and require supplemental oxygen, people who are hospitalized and require oxygen through a high flow device or non-invasive ventilation, and then people who are mechanically ventilated. And this is the group that had the largest benefit in recovery. Okay, so let's talk about JAK inhibitors now. This data is very interesting and somewhat confusing. So I think it'll be interesting to talk through it. Most of the research has focused on baricitinib, and so that's what I'll talk about today. So let's talk about, why people wanted to use JAK inhibitors for COVID-19. We know that JAK inhibitors actually have a pretty broad anti-inflammatory effect, and they decrease a number of cytokines, including IL-6. And, there was some early data that baricitinib has a theoretical direct antiviral activity through the interference with viral endocytosis. And so it could potentially prevent the entry of a virus into susceptible cells. So how interesting that this drug is both immunosuppressing and potentially has antiviral properties. And that's why the NIH chose this particular drug for the ACT-2 trial. So this was a large trial, 1,000 patients who had very severe COVID. They all required, oxygen or were on mechanical ventilation. And patients were randomized to either baricitinib or placebo, and everybody in this trial was already receiving remdesivir. And here are the results of the study. Overall, in the entire population, there was a very small benefit. So you can see that the median time to recovery was 7 days versus 8 days in the baricitinib group. So very minimal benefit here. But if you look at the individual, subgroups of patients, you can see that most of the benefit appears to be in what we call ordinal scale 6. These are the people who require, more oxygen support but are not mechanically ventilated. The other thing about this study is that it happened very early in the pandemic, and so very few patients are on steroids. So this is basically looking at baricitinib without steroids. Since that study came out, there has been another, very important study called COVE Barrier. This is not published yet, and the information that I'll share with you is just, in a press release. So we still need to, look at this study carefully. But this was a randomized, double-blind, placebo-controlled study of 1,500 patients with COVID. This is actually the largest placebo-controlled COVID study that's been done. So a very important study. And people were randomized in this study to baricitinib 4 milligrams a day for 14 days or placebo. And the important thing in this study is that 79% of patients receive steroids. So this answers the question, about whether baricitinib plus steroids are helpful. This study actually did not meet its primary endpoint, which was progression to non-invasive ventilation or mechanical ventilation. So it missed the primary endpoint, but interestingly, it met a secondary endpoint of reduction in mortality. So there was actually a striking reduction in mortality, 38% reduction in the patients who got baricitinib. And, as I said, many of these patients receive steroids. So we have to wait for the publication of this study, and it might change the standard of care, but we'll have to wait and see. So, right now, the current recommendation doesn't incorporate that last study because it hasn't been peer reviewed yet. But for now, I think because steroids are less expensive and easily accessible, really the recommendation is to start with steroids, and it's really only in the rare circumstance when steroids can't be used that the panel recommended to use baricitinib. But like I said, that might change depending on how we review that last study. Okay, so let's talk about IL-1 inhibitors now. And the rationale for using IL-1 inhibitors is that we see that the IL-1 pathways are upregulated in patients with severe COVID-19, just like in other conditions like CAR T-cell mediated cytokine release syndromes. And so people have looked at both anakinra which, as you know, is a recombinant IL-1 receptor antagonist with a very short half-life, or canakinumab, which is an anti-IL-1 beta, and it has a very long terminal half-life, 26 days. So the first study is the Coromino ANA trial. And this was a Bayesian open label randomized controlled trial of anakinra versus usual care. It was done in France. These patients all required oxygen, but were not yet mechanically ventilated. So these are sort of that intermediate group of patients, not the sickest patients. And everybody had some evidence of inflammation. You had to have a CRP greater than 25 to enter this trial. The co-primary outcomes were the proportion of patients who died or needed non-invasive or mechanical ventilation by day 4. And then they also looked at survival without the need for mechanical ventilation or non-invasive ventilation at day 14. Unfortunately, this trial was stopped for futility at an interim analysis of 102 patients. So it did not meet these co-primary endpoints. We also have this study of canakinumab, and this is called the CAN-COVID study. And it was a randomized double-blind placebo-controlled trial in 454 people who were hypoxemic, again, not mechanically ventilated. So it's interesting, you know, the IL-1 studies so far haven't looked at the sickest patients. They've looked at that intermediate group of patients, you know, before people get, you know, very severe. And this study was negative. It did not find any difference in survival without the need for invasive mechanical ventilation compared to placebo. They didn't see a statistically significant difference in deaths, but you know, the safety profile looked okay. So at this point, you know, we really don't have evidence to support the use of either anakinra or canakinumab for the treatment of COVID-19. And so the panel recommends against their use. Now, I will say that, you know, there is an exception here, and that is children who have, you know, a multi-system inflammatory state. You know, the pediatricians are using, you know, anakinra in that setting. And so this recommendation really applies to adults. Okay, so let's move on to IL-6 inhibitors. And this data is actually quite confusing, but I'll tell you what I think about it. So the rationale for using IL-6 inhibitors in COVID-19 is because, you know, people notice that many of these patients with hypoxic respiratory failure actually had elevated blood levels of IL-6. And we also know that infection with SARS-associated coronaviruses actually induce a dose-dependent production of IL-6 from bronchial epithelial cells. So maybe, you know, this drug could have a role in preventing ARDS. It's an interesting hypothesis. So people have looked at tocilizumab as well as sarilumab. Both of these are anti-IL-6 receptor monoclonal antibodies. And again, we go back to the recovery trial, which has made so many contributions to our understanding of how to treat COVID. So what recovery trialists did was for people who had been in the trial for less than 21 days, who were still hypoxemic, so O2 saturation less than 92%, and had evidence of a lot of inflammation. So the patients had to have a CRP greater than 75 to enter this part of the trial. And people were randomized to receive either tocilizumab or no additional treatment, and the outcome was 28-day mortality. Now, this slide has a lot of information on it. I don't expect you to read this, but I just wanted to create a slide that included all of the IL-6 studies. There's been so many, you know, with both tocilizumab and with sarilumab. And what I've done here is I've color-coded the outcomes. So the green rows are the trials that found benefit, and the red rows are the trials that found no benefit. And so you can see that the results are very mixed, right? Some positive trials, some negative trials. And, I tried to, put all of the differences between the trials in these columns. And one thing that really stands out is that the major positive trials, including the recovery trial and this REMAP-CAP study, which was also a very large trial, most of the patients in these trials received steroids. And most of the patients in the trials that were negative did not receive steroids. It's not universally true, but it seems to be a trend. So one possibility is that, tocilizumab with steroids is why we're seeing the benefit. The other thing is that it looks like, in the trials that had positive findings, the patients were generally more severe as well. So, most of the recommendations are actually driven by the recovery trial just because it was so large, 4,000 patients. It's a huge study. And the REMAP-CAP study, a very well done study in almost 1,000 patients. These other studies were generally smaller, 100 patients, although, a few of them were larger. So I think, most of the recommendation is based on these two studies. So in terms of the guidelines for people who require oxygen delivery through a high flow device or non-invasive ventilation, the panel recommended tocilizumab to be added to dexamethasone, and this is largely based on the recovery trial population. And then for people on mechanical ventilation, tocilizumab was recommended to be added to dexamethasone if people are within 24 hours of admission. And this is the REMAP-CAP population, so trying to sort of emulate the positive trials here. So I think tocilizumab has a role in these severe patients. Okay, so let's talk about colchicine. I never thought that colchicine would be used to treat COVID, but there is an interesting rationale. Colchicine has some mechanisms that are potentially useful for COVID. So, it inhibits inflammasome signaling, and we know that IL-1 is important in patients with COVID, so maybe this could be helpful there. It also, it has mechanisms that reduce the chemotaxis of neutrophils. And if neutrophils are causing damage in COVID, then maybe colchicine could be helpful in that regard. And then, importantly, colchicine is inexpensive and easier to access than some of the, biologic drugs. So we go back to the recovery trial, and they took hospitalized patients who had COVID-19 and had an additional randomization to either no additional treatment or colchicine, and then looked at 28-day mortality. And they used a high dose of colchicine. People got 1 milligram loading dose, and then they got 0.5 milligrams 12 hours later, and then they got 0.5 milligrams twice a day for 9 days. So they gave people, a decent dose of colchicine. Remarkably, they randomized 11,000 patients. I mean, just think about that. That is just unbelievable. 11,000 patients were randomized. And they found, unfortunately, that this drug did not work. There was no difference in the primary endpoint of 28-day mortality at all. And one thing that I'll say is that, colchicine was added to steroids. 94% of these patients had been receiving steroids. So this trial showed that colchicine, in addition to steroids, doesn't work. Now, we also have this very interesting study of colchicine in outpatients, and it was called the Col-Corona study. It was performed out of Montreal, and this was a randomized, double-blind, placebo-controlled trial that randomized people to get colchicine 0.5 BID or placebo. And people were enrolled very early, within 4 hours of having a positive screen for the study, they receive the study drug. And one thing that was important about this study is that, well, besides the fact that it was done in outpatients, was that they allowed people to either enter the study if they had PCR positive test for COVID, or if they had a presumed infection because they had a close contact or they had symptoms that were consistent. Now that's going to become very important on the next slide. So just remember that, not everybody in this study had PCR confirmed COVID. And the patients in this study all had to have risk factors for poor COVID outcomes. So they were over 70. They had a body mass index of more than 30. They had diabetes or hypertension and so forth. So this is a high risk group of outpatients that they tried to apply this drug to. The outcome in this study, the primary outcome, was looking at death or hospitalization by day 30. And they pre-specified that they were going to look at the PCR positive patients separately. Unfortunately, the investigators decided to stop the study when they were about 75% enrolled, just because they were having a lot of logistical difficulties sort of maintaining this very intensive study. So 93% of people in this study had PCR positive confirmed COVID, 7% did not. And it was a very large study, 2,000 patients randomized to colchicine, 2,000 patients randomized to placebo. And here you can see that for their primary composite endpoint, they did not meet their primary endpoint. They just missed statistical significance. The p-value was 0.08. But when they looked in the people who had PCR proven COVID-19, they found that there was a very slight reduction in the primary composite endpoint. So 4.6% in the colchicine group, proceeded to get worse versus 6%, and that just made statistical significance. Importantly, as rheumatologists, we know that when you use colchicine, there are adverse events. They saw a lot of gastrointestinal adverse events, just like we would expect. Colchicine causes diarrhea. I don't know what to make of the higher pulmonary embolism in the colchicine group. I wonder if that's an artifact. We've been using colchicine for a long time and we haven't seen this, but they did find that too. So, in terms of, what we recommended for COVID treatment with colchicine, I think, unfortunately, in the outpatient setting, there really is insufficient data. The trial didn't, complete 100% enrollment, and it's only in the secondary analysis of the PCR positive patients that it looked like there might be a benefit. The number needed to treat in this study, even if you look at that PCR positive population, is 70. So, a very, very small benefit, and you're going to give a lot of people gastrointestinal side effects. So at this point, it gets an insufficient data rating. And then for the inpatient, because of the, huge recovery study, we recommend against the use of colchicine on the inpatient side. Okay, so let me just summarize some of the research that I think rheumatologists should be aware of. I think we get asked about this, by our colleagues. So first of all, we all know now that hydroxychloroquine has no impact on any stage of COVID. I think we've learned from many of these studies that the timing of immunosuppression is key. Starting with dexamethasone, when people are in the early phase of their viral infection and probably the innate immune system is active, using a broad immunosuppressive drug like steroids is possibly even harmful. But later, when people enter the inflammatory phase of the disease, these anti-inflammatory drugs seem to decrease morbidity. And so far, it looks like the data show that dexamethasone and tocilizumab may have a mortality benefit for a select group of patients. And I've shown you some very preliminary data that baricitinib may have a mortality benefit, although like I said, that study still needs to be peer reviewed. We don't have data right now to support the use of IL-1 inhibitors like anakinra or canakinumab. It looks like colchicine doesn't work at all in hospitalized patients. And it looks like, there's either no benefit or very small benefit in outpatients. And then finally, I think the people treating COVID now realize the predicament that we have in rheumatology, which is that the breadth and heterogeneity of abnormal immune responses is vast to COVID-19. And what we really need is immunophenotyping, just like we need in rheumatology. We need precision medicine approaches, basically to know which patients will benefit from which drugs. So this is the overall therapeutic management strategy, starting with not hospitalized patients all the way to patients who require mechanical ventilation. I've focused, most of my remarks today on the anti-inflammatories that are recommended, for the patients that are more severe. For the people who are not hospitalized, which I think, this is an interesting group of patients with rheumatic disease, for example, are patients who are very immunosuppressed. There is data to support the effectiveness of these monoclonal antibody treatments. And because of the variants, we're now using combination therapy. So it's nice to have something to offer outpatients as well. Okay, so with that, I just want to thank all of the people who have spent, hundreds and thousands of hours making this guideline in real time. It's been quite a huge amount of work by some very dedicated people. So thank you so much.